We will go on to talk about the role of the hospital epidemiologist. I don't have any conflicts of interest. We'll jump right into a case. 47-year-old female with a history of an MRSA skin and soft tissue infection of her left leg requiring a recent admission for IV antibiotics presents to the hospital with an abscess on her arm and is admitted again. She has had several abscesses since her last admission. She usually applies a warm compress and they drain on their own. One time she had to go to urgent care for an IND and she was released home. With her recent history of MRSA, she is placed into contact isolation. She decompensates after admission to the floor and is transferred to the ICU. Her screening lab in the ICU for MRSA of her nares returns positive. The Infection Prevention and Control Department is then provided audit information over the next several days regarding hand hygiene and compliance with contact isolation of healthcare workers entering her room. We do that right now with two methods. One is an app on the phone of particular individuals who enter that and watch us wash our hands and enter rooms with gowns or not. And the other, we are beta testing in 3 units with a thing called BioVigil. There's a sensor on some nurses' jackets and one above the threshold of the door. And if that's passed, then you have to wave your hand in front of it, and it senses the alcohol, saying that you've washed your hands. We'll talk a little more about that later. So who said to wash your hands first? It was Ignaz Semmelweis in the 1800s. His first job was at a hospital, and he noticed that there were a lot more mothers delivering babies dying on the physician side than on the midwife side. So he tested his hunch and looked at the numbers, and he was right. The mothers were dying on the physician side a third as much, twice as much, sometimes 4 times as much. You can see in 1945 in particular, that was a bad year. Here we have 7% for the physicians and 2% for the midwives. So he thought to himself, what's different in these 2 wards? And he noticed that on the midwife side, they would have the women deliver on their side. Whereas on the physician side, they would have the women deliver on their backs. So, everybody on their side. Crunch the numbers again, no difference. So he said, okay, what else is different? Well, he noticed on the physician side that when a woman would die, a priest would walk down, around, all the while tolling his bell. So he said, you got to change your route and ditch the bell. So that's what he did, and he crunched some more numbers. No difference. Anyway, he needed a break and went to Vienna to look at some art. And he was there a month. When he came back, one of his pathology friends had died. And so he came to find out that the friend died from the same disease that the woman died from that was delivering her baby. So he made the conclusion, we didn't know that this was transferable to, men, so that must be cadaveric particles that was transferred from the women to the men. And so he knew that the physicians that were delivering the babies also did autopsies in that day. And so if they were doing an autopsy and then the woman went into labor and they ran over, they weren't washing their hands. So he said, wash your hands. And then their rates went down. So he found the thing that caused these deaths, and their rates finally went down. Now, that guy lived a long time ago. So we kind of need a bridge from that guy that lived a long time ago to today, and that bridge is Louis Weinstien. This man was key in infectious diseases. He taught generations of medical students. He was born before the antibiotic era, essentially. He wrote guidelines about antibiotics. He preached that the overuse of broad-spectrum antibiotics is bad. He showed that you could have an infection, a secondary infection, because you're on antibiotics for a primary infection. He said that you could make house calls, and he did. He had journal club on Monday nights for the medical students. In 1949 to 1955, he was appalled by the OB surgeons who would not deliver the women who had polio because they thought they'd catch polio. so he delivered them to himself. Quite a man, quite a man. And so that brings us all the way to today. And who is here today? We have in our own division Dr. Ruth Carrico, who's very approachable. I didn't tell you that Semmelweis would berate his physicians for not washing their hands. And Weinstein was a little arrogant and would always try to one-up his physicians. Dr. Carrico is very approachable, but no nonsense at the same time. We all go to the CDC and the FDA to find their information, and I'm not trying to leave you out, Dr. Ramirez. The FDA and CDC comes to both of them for information, and we're happy to have both of them here in the division of ID. So the next epidemiologist is perhaps sitting right over here, and they are going to build on the knowledge base and the good qualities of Semmelweis, Weinstein, Carrico, and we'll see who that will be. My outline today is to talk about a multidrug-resistant control program. An antimicrobial stewardship program and an infection prevention and control department are key aspects of that. The strategies to prevent and manage multidrug resistance, a literature summary, and finally an application. So let's talk about the multidrug-resistant control program. You have to have a successful one, an antimicrobial stewardship program and an infection control program, and the hospital epidemiologist serves as the link between those two. So all this together makes a successful multidrug-resistant control program. At the Uofl Division of Infectious Diseases, that's us, we go to Uofl Hospital and the VA Hospital. So we have programs at both places. I'm the hospital epidemiologist here, and Dr. Bevan is over at the VA. Each hospital has its own antimicrobial stewardship team and infection control committee. And on those committees are various members of the University of Louisville Division of Infectious Diseases. Now, what happens at each hospital depends on who is in charge. At the moment here, it's Kentucky 1, and we're about to regain control here July 1st, so we can influence more what happens here. At the VA, there's a national mandate that happens. So there are some differences. For example, the signs on the doors for isolation will look different at each hospital. And when in Rome, do as the Romans and do what the door says, right? So let me answer what a multidrug-resistant pathogen is. You can have multidrug-resistant, extreme drug-resistant, and pan-resistant, resistant to everything. The common examples are MRSA and VRE. And the CDC has rated these 4 out of 5 stars for significant antibiotic-resistant threat. So our MRSA rate is about here. It's trending down slowly over the years. As you can see, it's still significant. And our VRE is a bit lower. And some years, months, we've even had areas where we haven't had any VRE bacteremia or infections. And so this, too, is trending downward, which is good. So the multidrug-resistant pathogens that are given a 5 out of 5 stars are not what you would expect. Neisseria gonorrhea, C. difficile, and CRE. CRE is carbapenem-resistant Enterobacteriaceae, and these are more bugs that you've heard of: E. coli, Proteus, Citrobacter, Serratia, Enterobacter, Klebsiella. What's not in this list are Acinetobacter and Pseudomonas. They have the resistance of their own that you're familiar with. So what is the prevalence of CRE at Uofl? Well, I can't throw up a graph like I just did for MRSA and VRE because we don't check. But we have done a point prevalence study where we took a day, usually a week, and we had a study where we swabbed everybody in the hospital to see if they were carrying a CRE. So the swab is a perirectal swab, and this is what it checks for. Multiple genes that carry resistance for CRE, a couple for ESBL, and the swab also had with it the gene for VRE, which is called VAN-A. So what we started with was 264 people in the hospital. When we approached 2 rooms, the people had died, so obviously we didn't swab them. And we didn't go to the psych unit just to refrain from all the issues that might come with that. So there were 8 other people that were out of the room. 26 people said thanks, but no thanks. And so we swabbed 214. So for a perirectal swab, to get 86% was pretty good for the hospital. It gave us some good information. So what we found, we actually had 2 CREs in patients that we didn't know about. They were carrying it and not infected. 7 ESBLs, which is extended spectrum beta-lactamase, and 24 vancomycin-resistant enterococcus. So the 2 CRE are the 2 most interesting patients here. One was a patient who came for urgent surgery and had been here for 3 weeks on the day that we swabbed him. And the other was an elective surgery patient who had been here for 2 days when we swabbed them. Now, if you consider this to be a floor plan of the hospital, let me orient you. Here's the elevators. So if you get out of the elevators and go right, you go into the ICU. You go straight, you go in the south wing. You go left, you go to the east wing. So this then would be the entire hospital, 9th floor down to the 3rd floor. And our 2 CRE were located here in the SICU and on 5 South. If you look at just the east wings, you can see that they were positive for anything tested. 3 on 9 East, 1 on 8 East, 2 on 7 East, 9 on 6 East. Most of those were Van A's, and 0 on labor and delivery. Then in the South, we had 2 on 9 South, 2 8 South, 1 7 South, 2 6 South, 2 5 South, and 1 in postpartum. She just delivered her baby. Then in the units, we had 4 in the SICU, 1 on CCU, and 3 in MICU. 2 of those were Van A genes. So, 2 components I mentioned, antimicrobial stewardship team. Let's talk about that first. Antimicrobial stewardship is a national term. The Joint Commission uses the term. It's not a Uofl phrase and certainly not a Forrest Arnold phrase that I made up. It does make a little bit of sense, though. A steward, as we know, is somebody who takes care of passengers on an aircraft or a ship or a train, and they are not in charge of flying the plane, but they are there to make life better for those who are riding. Now, an antimicrobial steward is someone who is there to make sure that the antibiotics are used optimally. Again, they're not there to make a diagnosis or fly the plane. They're there to make sure the drugs are used optimally. So these new guidelines are short, but they say a few important things. The hospital leadership is to establish antimicrobial stewardship as a priority. Not just to say, we have one, but a priority. They also say that the team should be made up of infection control, infectious diseases, and pharmacy. We have them, plus we have microbiology. We have physician representation from the ER, from family medicine, surgery medicine, and internal medicine. We have nursing representation, and come July 1st, we'll have somebody from quality. They also say to educate the staff, and that is people who order the antibiotic all the way to give the antibiotic and then monitor the antibiotic. So anybody that has to do or touch the antibiotic is to be given some education about antimicrobial stewardship and resistance. And this is to occur at orientation, and then it says periodically. So it also says to monitor prescribing and resistance patterns and report information to doctors, nurses, and relevant staff. One way that we can do this is with an antibiogram. So this is an example from a year. It's ICU patients who were there for at least 3 days. And what it does is it, for example, collects everybody who had, say, E. coli. There were 73 of them, and 34% of them were sensitive to ampicillin. It says 94% of them were sensitive to piperacillin tazobactam, and 100% of them were sensitive to amikacin. So this is good information to know when you're in a specific unit and you want to know what empiric therapy you might use. Maybe not just vanc, pip, tazo, and levo. So the stewardship team is to use organization-approved multidisciplinary protocols. So it gives some examples. And one is the formulary, and another is the hospital guidelines for CAP, skin and soft tissue infection, UTI, and C. diff. So what's very specific to Uofl or the VA is the formulary. But what is not, it's no secret what's in our local guidelines for pneumonia or UTI, because it's drawn directly from what the national guidelines say. So, for example, if you write simple UTI in the record, and then you proceed to give the the patient 3 days of antibiotics, and then you go to a fourth, that's going to prompt a note from the Antimicrobial Stewardship team who says, you said the diagnosis is simple UTI, we see the guidelines say 3 days of antibiotics, and they're on a fourth day. And then we'll give you a day to respond to that and see what happens. So the hospital is supposed to take action on improvement opportunities identified in its antimicrobial stewardship team. So, for example, if we see the overuse of one certain antibiotic and the increase in resistance, we may make a note that this antibiotic and disseminate the information that this is becoming resistant. Another example might be that pharmacy and microbiology use a program called Theradoc, and that's going to need upgraded soon, and so that would be an investment to do that. They haven't made that request yet, as far as I know, but that would be an improvement on the opportunities. So overall, the goals of antimicrobial stewardship are to optimize antibiotics for patients, to be a resource to prescribing physician and record data, and then do what with the data? Well, to provide feedback is our goal. We've done that in the past. So one idea is to provide a report card. Who likes report cards? Nobody. But if it improves antibiotic use, then I'm all for it. If you recognize this door, this is the fanciest restaurant in Louisville, and how do you think Edward Lee feels about, he's the master chef there, about this dorky, cheesy-looking sign on the side of the door that says A? Well, he may not like it, but as a customer, if I was ever to go there, I really like looking over as I walk in and seeing that A there. So this example breaks down a little bit because I'm talking about giving report cards to physicians about physicians, not report cards to patients about physicians. But that's an idea. How would that go? Hello, ma'am, here's your report card. Looks like your doctor got an A for his antibiotic use. Well, good. Sir, your doctor got a C, but that's average. Here you go. Physicians to physicians. So let's now talk about infection control program. The epidemiologist is involved in a lot of things. The way it's set up is we have a department, the epidemiologist, the director, and at Uofl we have 3 infection preventionists. We report to the committee, and the committee reports to the medical executive committee and administration. So we're in charge of reporting specific infections, MRSA, VRE, multidrug-resistant gram-negatives, and C. difficile. And then we're also have to report specific infections, hospital-acquired infections, line infections, catheter-associated UTIs, and ventilator-associated pneumonias. So the epidemiologist is involved in employee health. So occupational exposures to infectious agents is typically your needle stick or splashes. The epidemiologist will come and determine if that's been a true exposure and determine if the employee needs to have HIV preventive care, vaccinations, tuberculosis screening, and the epidemiologist gets involved when it's positive and they need treatment. Outbreak management, this is a very interesting part. If you remember the scabies outbreak we had among the employees after a patient was diagnosed, and then just be a resource to the employee health nurse. So we're involved in engineering as well, and we perform what's called infection control risk assessment. And we're involved in any kind of construction. It could be if a bed knocks the wall and puts a hole in the sheetrock, engineering can't just come up and fix it. They've got to contact infection control first and get this permit, or it could be large construction. Here is on 5 South where they're remodeling, and that sign is for nobody but infection control. It tells us that this is not just a vent that's blowing out all the fungus they have going on in there, but this is HEPA-filtered air to keep the rest of the hospital clean while they do that. You should recognize this is the new pediatric building that's going up. This is west of the hospital, which means that the wind blows from west to east, And if you notice down here is a large moat of nocardia. And so our filters have to be managed well and made sure that the hospital air intake is not just pulling all that in. So our intake is on the south side, fortunately, of the building. Here's the waterfall at the HCOC. This is tested regularly for Legionella, and it's not been positive. So any fountain like this is something that we look at. Infection control also goes to the operating room weekly. They check healthcare worker attire. They check traffic there. And we report specific surgical site infections. A couple of them are abdominal hysterectomies and select colon surgeries. So that goes to a national database, and then they plot you where you are along with other institutions. So I want to talk about strategies to prevent and manage multi-drug-resistant organisms. Hand hygiene is the premier way, as Semmelweis showed us, of preventing infection. So we're to do that as we go into a patient room and as we come out. There's two types, alcohol and soap and water. We have policies about this, and then there's a lot of education that goes on about this. So this is some of the feedback that I mentioned earlier. This is from the handheld device that you can do on your phone, and it's sent to us. This is 4 months of data. We have 1,000 responses, so those were 1,000 times that people were given the opportunity to wash their hands. Somebody like occupational therapy, physical therapy, they're pretty good, 97%. That's 167 out of 177. Physician attending, 68%. There's some medical students, 73%. Oh, but the residents, 56%. Semmelweis would not be happy. And neither am I, frankly. This is from the handheld device that clips to your jacket and the sensors on the door. And really, I don't want you to look at all the busyness on this slide. Just one number, and that's right here. 27,000 instances where we could look to see when people went in and out of the rooms and were supposed to wash their hands. And that's from 1 month. Just 1 month and 3 sites in the hospital. And physicians weren't a part of that. That's why it was 97%. Anyway, there are different types of isolation precautions. You're familiar with most of them: respiratory, contact isolation, contact-enteric, droplet isolation, containment isolation. I'm going to go through these. And exotic pathogens, Ebola and SARS. I am not worried about you all complying with the isolation precautions for an exotic pathogen like Ebola, because number one, you'll be super highly motivated to comply, and number two, we will have room-side education of anybody going in and out of those rooms, plus the CDC would be here telling us what to do. So that's kind of taken care of. The rest of the isolations, you have nobody looking over your back. It's just up to you and your conscience to tell you whether or not to do what the door says. So with respiratory isolation, it simply says to wear an N95 mask, and the main example here is tuberculosis. With contact isolation, we have the main ones are MRSA, VRE, and multidrug-resistant gram-negatives. Mark, why don't you come up for a second? So this is the sign. We have gowns and gloves, and I hear a lot of feedback about, gowns take too long to put on. So we're going to have I want you to time me and tell me how long it takes me to put on this gown here. Just tell me to go.
Go.
Hold on a second. Hello? This is Dr. Arnold. That order's in? Yes? Yes, ma'am? Okay, thank you. Just keep going. All right, how long?
33 seconds.
33 seconds. All right. Not long at all. So the gowns don't take too much time. That's good. Let's go to Contact-Enteric Isolation. This is mainly for C. diff, norovirus, and other infectious diarrhea. We have purple signs for that, and the main difference is that you wash at the sink with soap and water to wash the spores off so that you don't take those to your next patient. Droplet isolation, mainly for influenza and Neisseria meningitidis. The sign looks like this. We wear a surgeon's mask because the particles are large, gowns and gloves, and I've written arrows here to show that all these fall. So somebody that has influenza, sneezing, it comes out, but then they're heavy and they fall. There's about a 3 to 6 foot radius of all this stuff around the patient. And so it's not coming out and then floating down the hallway like tuberculosis. And that's why we take the gowns and gloves as well. Containment isolation, these are for carbapenem-resistant organisms, the most famous of which is KPC, Klebsiella, pneumonia, carbapenemase. Also, surgeon's mask and gowns and gloves. Another difference being that we use patient-dedicated disposable equipment and minimize patient transport and call infection control before you transfer. Nobody wants to receive somebody with a XDR that's a surprise. So some people say that behavior modification only comes through prayer or suffering, and nobody likes to pray. So we see that in our patients. A lot of the patients with coronary artery disease, they start exercising after they have an MI. Patients with diabetes, they start being compliant with insulin and their medicines after they have DKA episode. Our patients with infectious endocarditis, tricuspid valve replacement is what drives the patient to stop using IV drugs. In our HIV patients, some of them don't start taking medicine that's paid for them and mailed to their house and one pill once a day until they have AIDS. Now we know that there are many exceptions with patients in all these categories. You have the patient who continues to smoke after they have lung cancer. So our motivation infection control to have other people use hand hygiene and isolation precautions is a bit easier because we're working with professionals. It's all of our jobs to do a good job at what we're doing. But our problem is, whether we're working with patients or professionals, is human nature to be selfish. So with hand hygiene and isolation, most people wear that to protect themselves, which is only partly true. Consider the isolation type, respiratory isolation. Yes, you wear an N95 mask for yourself because that's how you get tuberculosis. You breathe it in. Okay? Well, as I said, human nature goes against the golden rule, love your neighbor as yourself. What part of respiratory isolation is for your neighbor? And I say it's the anteroom. Have you walked by somebody who's in respiratory isolation? You're in the hallway. The anteroom door is open. The patient door is open. You can see all the way to the bridge over the Ohio River, which means that negative pressure is interrupted and the tuberculosis is just wafting out in the hallway. You can smell it. So that's never good. We want to close the doors. So with my team, to imprint this in on their minds, we all cram in the anteroom door. It's a bit uncomfortable just for a moment while the door's closed and then open the next one. So they think, this is uncomfortable, but we're doing this for a reason, to prevent those outside from getting TB, because they don't have masks on. Contact isolation, we don't really wear contact isolation for ourselves. If you're not immunosuppressed and your skin is intact, you're not going to get MRSA. Now, having said that, if you have someone who has a large MRSA wound and you're changing the dressing, and you can insert your gross MRSA abscess picture here if you want to, then obviously wear a gown and gloves. I say, show me someone who touches a draining MRSA wound with their bare hands, and I'll show you someone who will live a lesson about personal protective equipment. I couldn't find anybody that said that, so I'm taking credit. So what we do to this point is wear gowns and gloves to prevent our patients from getting MRSA and VRE. Let's look at Contact-Enteric. Again, you're not going to get to a room of a patient with C. diff and acquire C. diff yourself. You have an immunocompetent system. okay? It's to prevent it from taking it to your neighbor. So we wear the gowns and gloves to prevent taking those toxins to them who are on chemotherapy or immunosuppressed or have AIDS. And then we wash our hands at the sink instead of the alcohol gel. For droplet isolation, we do wear the masks for the reason I said. The whole way you get influenza is to breathe it in. And so the surgeon mask is for that. The personal protective equipment is the same thing. You can lean up against the bed rails, get that on you, and then if you scratch your eyeball or you don't want to take it to the next patient's room. So it serves a dual purpose, and then we don't want to infect ourselves or others. Then containment isolation, again, you're not going to get multidrug-resistant whatever yourself. If you're immunocompetent, then you're going to be fine. And the multidrug-resistant organisms are never going to be able to compete with your normal flora as far as taking over colonization. But we do wear the personal protective equipment until we have data that tells us not to. Now, I started this section by talking about behavior modification, and I'm going to finish that before moving on to things. We all do things we regret and don't do things we wish we had. Those young in medicine over here may be quick to blame the location of the alcohol dispenser or how dry their hands get with the alcohol or the smell of the lotion in the nurse's station. Those, and I won't say older, but more mature, will be more honest to blame themselves. Have you ever said, everywhere I go, there's always the same problem? After a while, you come to realize, it's me. We come to the realization that we need accountability. I have mistakenly walked in a room without a gown before, and I know it'll happen again in the future. So I have instructed my team to immediately inform me when that happens. Throw me a gown. I can put it on quickly, 33 seconds. It's okay to speak words of accountability to those above you as well as on your level or below you. And across disciplines. So nursing, OT, respiratory therapy, we should all be exchanging words of accountability. The VA has this poster. It's a good message. It's okay to ask if I've cleaned my hands. Finally, there's a posture that comes with maturity and behavior modification. It's the difference between willfulness and willingness. One says, I'm going to try harder, and yet we never achieve it. The other says, I'm going to be part of this policy, this infection control committee decision, this community of people to move forward. Part of the responsibility of the infection control committee is to enforce its policies. Between the 5 of us over there in the department, that's a joke. We all have to be the enforcers through accountability, through example. Consider this view of a nursing assistant in the nurse's station. She's looking across. There's a physician there entering a room. Now, she has learned to wash her hands before she walks in the room. This doctor has no idea she's being watched, but the nursing assistant says, hey, I see that doctor washing her hands as she walks in. I'm going to do that too. So let's move on to the last thing that epidemiologist does, which is an outbreak. And I'd like to spend a lot of time with this because it's very interesting, the outbreaks. That's where you get out of the ordinary and into something new. And I'll just quickly go over the most recent outbreak we had. It was with a spine stimulator. Now, this is not a pain stimulator. This is a spine stimulator. It's to take somebody who's paralyzed in a wheelchair, make them stand, and finally make them walk on their own with assistance. The stimulator is put in the back, and the wires wrap around the side, and then the pulse generator goes in the abdomen. Well, here's a patient. You can see, it's a blurry, sorry about that. You can see where the wires are in the spine. This is not a scar. This is cellulitis that has popped up exactly where the wires are, up to the pulse generator in the front. So you can imagine that this had to come out. So when we work up an outbreak, and I won't go into all the details, but we do a root cause analysis and come up with different categories and then different items in each category, all to try to explain the reason for the outbreak, which is here post-op wound infections. And we come up with different variables, and if we had more time, I'd go over them. And then we make conclusions to the people in order to try to arrest the outbreak. So I want to go back and talk about this circle right here, because I talked about using personal protective equipment if you have for contact isolation. And I want to go over some of the data there that's with that. So in order to do that, I'll do a literature summary. Now, after Dr. Roman got here, he was on service up in the ICU, and he asked me a question as I walked in there. He was like, what is the data that shows we will really prevent infections of other patients if we wear gowns and gloves? And I hope I directed you to these following two documents: the management of MDRs from 2006 and the 2007 guidelines for isolation precautions. And for this lecture recently, I got in there and I tried to pull out articles, and what I found was there's not that many. And the only time that an article was published about contact isolation is when there was an outbreak. And when an outbreak happens, you don't just apply one intervention and then another intervention several months later. No, you just throw everything in there and try to make the outbreak go away. And so that's what happened with these early studies. And here are all the interventions, and just some of them actually, not all of them: hand hygiene, active surveillance of cultures, education, contact precautions, enhanced environmental cleaning, improvements in communication. So it was just a number of interventions that are all done at once, and then you don't know which one really helped, and it may have been a combination of several. So here's one example of an early study. You see that there are two phases here. You had minimal isolation and screening and neomycin nasal cream used in 1989 up through 1990. And then phase 3 is single room isolation and nurse cohorting, contact screening, prompt discharge of MRSA cases, and mupirocin nasal cream. And then the rates began to fall. So that's good, and that's one that supports the use of contact isolation. You see that it's one of the several aspects that are thrown in there. Here's another article. It doesn't support contact isolation very well, but it's early, and it was also referenced. This is about VRE, and so this is people in an ICU that were positive for VRE when they got there. It's about same in both groups, and both groups are glove and gown, and then a glove-only group, so no gowns. So the acquired VRE in the ICU was about the same. This is statistically significant because the numbers are small, 24-21. The negative for VRE enterococcus was the same. The acquired VRE after discharge, that means probably on the ward because they weren't discharged home yet, was approximately the same. And they had about the same amount of time until they acquired the VRE. So we're up to 1996. In 2000, you've got this study which shows before they used no control measures, and then they had their outbreak, they start using single room isolation, and they started isolation screening, mupirocin, and then in phase 3, they do everything in phase 2 plus, well, they started washing their hands. That's a good idea. Education and feedback program. I'd be embarrassed to publish that. You'd think it was supposed to be over here. Anyway, it started coming down. Here's another article that showed that there were 3 periods. The first year was where you wear a gown, and the next period was 1 year, no gown, and then 6 months where you went back to wearing the gowns again. And what they saw was that the VRE colonization went up when the gowns were taken away and went back down when they started wearing the gowns. Overall mortality stayed the same with the gowns, without the gowns, but then went down when they got to the 3rd period where they were wearing the gowns again. And then any VRE positive blood culture was 4, 11, and 4. This was significant with this many patients involved. And then VRE bacteremia was minuscule, 1, 3, and 2. So all those studies led to a statement like this: no well-designed studies exist that allow the role of isolation measures alone to be assessed. Nonetheless, there is evidence that concerted efforts that include isolation can reduce MRSA even in endemic settings. Current isolation measures recommended in national guidelines should be continued to be applied until further research establishes otherwise. Well, here's some further research. Here's UCLA hospitals, and they had a time period before they stopped contact precautions and then after they stopped contact precautions. So they used it here and they didn't use it here. They have 2 hospitals at UCLA. They measured both of them. They started one here, and you can see the combination. The rates go up and down, but it's about the same overall. This is MRSA. Here's their VRE rate, which is essentially the same as well. They did use contact precautions, and then here they took it away. So there's also patient care and well-being in contact isolation. What they noticed, these 3 studies noticed that the attending is half as likely to enter the room if the patient is in contact isolation, which is fine if they have to be in contact isolation. Increased anxiety and depression score of the patient. If they're in contact isolation, the patients had more preventable adverse events, greater dissatisfaction with their treatment, and less documented care as well. So here's another recent study from last year that shows that outcomes of mortality, 30-day readmission, 30-day ED visits were all the same. But what was significantly different was the people that had isolation contact had a longer length of stay and they cost more. So now let's go to an application. As of this time, today, when you finish here and go upstairs and see your patient, we have contact isolation for MRSA, VRE, and MDR gram-negatives. There's no contact isolation for patients with MSSA, vancomycin-sensitive enterococcus, and sensitive gram-negatives. So what we're going to change is move MRSA and VRE over to the no contact isolation, and that's going to be as of May 15th, Monday. Now, what stays the same is that hand hygiene, respiratory isolation for tuberculosis, a new community-acquired pneumonia admission still goes into respiratory isolation until they're ruled out for TB, droplet isolation, contact-enteric isolation, containment isolation, Ebola isolation. It's all the same. Now, to get this a good example, I have a religious example. So before you barrage me with emails for using a religious example, hear me out. If I tell you that I'm a Christian and I say Jesus died for my sins, and I proceed to tell you because I'm free, I'm going to go raise mayhem and commit adultery and fornication and embezzlement, then you would say, if you were a Christian or not a Christian, you'd say, I don't think that's what that means. Now, we're doing away with MRSA and VRE isolation precautions, and if you hear someone say, hey, they're throwing away the masks and they're putting all the isolation carts on the street, I hope you would say, I don't think that's what that means. And after this lecture, I hope you would say, I know that's not what that means, and don't forget to wash your hands on the way in and on the way out. So, in conclusion, we have talked today about a successful multi-drug-resistant program. And it encompasses antimicrobial stewardship team and an infection control program that are linked by a critical hospital epidemiologist. I've gone over some basics, hand hygiene, isolation precautions, some complexities of behavior modification, literature review, and data analysis. So I think I've covered all the objectives. I've even covered some religion. The only stone left unturned is politics. And so with this next slide, this lecture is done.
Are you done, really?
I'm finished.
So everybody needs this kind of program. How much does it cost the organization, the hospital, whoever it is, to have a cohesive, well-developed program like the one you have?
Antimicrobial Stewardship and Infection Control Program?
Yeah.
Cost? I have no idea.
Okay.
I don't do money.
Does anybody here know? Do you have an idea of what is it?
Oh, save?
Yeah.
I know the cost, but most of the savings are things that don't happen, so you can't measure them. So we can show them last year we had a 41% reduction in catheter-associated urinary tract infections, but Yes, each of those usually costs about $50,000. The total cost of this program is right around $500,000 a year.
Okay. So I am, things are bubbling up as he's talking. The Antimicrobial Stewardship team keeps track of the switch from IV to oral, for example. And we have numbers from Jewish and from here, and it ranges from anywhere from like $40,000 to $60,000 a month where you've switched because the oral is so much cheaper and people get discharged. Now, we used to give an arbitrary savings for every day that you're discharged, you save $1,000. But that's an example I can think of.
I think the point I want to make is that these things seem expensive, but they have a tremendous impact, and we rarely spend the time measuring the impact to show that it's worth to sustain this operation. Although at our place, there's no concern that you shouldn't sustain this operation. No, we believe in this. No, there's a religion part of it.
Right.
On the other hand, it would be nice to continue to do what you're doing, which is to do the objective part of it, to say, no. There's good data that says we make a big impact.
Yeah, so you showed the lead with an erythema.
Right.
How do you know that that's, you said it was cellulitis, but how do you know that that was cellulitis and not a contact dermatitis? Did you culture out organisms that proved that it was, and was it in multiple patients that same erythema occurred?
It had a couple.
So we see in dermatology, we're sent patients who have cellulitis, bilateral cellulitis of the lower legs, and it usually is stasis dermatitis. Whenever anybody throws out that term, I have a question what the differential diagnosis is and how it was proven.
Well, it is a vague term.
Remember, you've been questioned by the chair, the chief of dermatology, Logan now.
You're right. Thank you for that question. The term cellulitis is vague. It just means inflammation of the cell. Now, there were other things surrounding this, such as there was an open area that had some pus draining out. I didn't go into detail. I would like to talk about outbreaks a lot. She ended up having hers out, like I said, and I didn't tell you what they found, which the whole pocket was full of pus. But to have a contact dermatitis, that would be something to think about before you go to all that invasion, especially without it. There's no potential for her to stand and walk like you're saying. I also didn't say earlier that people, for example, if they're admitted with a diagnosis that's totally not related to infection, say a seizure, and they come to the hospital, they get hospital-acquired influenza, that would be a disaster. And if they die from influenza pneumonia, that would be a tragedy. So you're saving, how do you quantify that in dollars?
I really liked your show of how PPE protection is not doctor, but it's for everyone else. Just yesterday, walking by the construction zone, I crossed paths with a physician still wearing their skull cap, still having a surgical mask, and their shoe booties on. How is the perception that they're not dragging something from wherever they came out into the environment? Shouldn't they be discarding all that before they left the room that needed it in?
Yes. And so
wearing all of that while they're walking from hospital A to hospital B, whatever. What is a common person or a patient or someone who's just, civilian walking around supposed to think?
Well, they're going to think, hey, you're bringing nocardia in here if they know that term. But you're right. That's not the policy. And some areas like that, if you know the person, you could approach them if you know them or not. But also, the Infection Control Committee is down here. We can be called, and then we can contact the person. Everybody is nice and sweet down there except me. So that's one option. But you're right. He was not setting a good example, and that is not the policy.
So, somewhat related, I noticed that both you and Jesse are wearing long sleeves.
Yes.
And Jesse's got a wedding ring on. I don't know if you have a ring on or a watch. Many countries have now said bare below the elbow.
Okay.
And we know that we can culture the edges of our lab coats or our neckties, underneath our watch bands, and we can hand wash all we want. We still can't get it out from underneath a ring or a long fingernail.
Right.
What would it take policy-wise to go like the United Kingdom's trying to go, which is bare below the elbow?
So if you go bare below the elbow, whatever the top surface is going to get colonized. So if they're really serious about that, they should say, okay, scrub up past the elbow in between every patient. You can't take off your skin. There's going to be a top surface, whether it's your arm or a shirt or a jacket. And then certainly we need to keep them clean. A coat cuff?
Just like the other example, you walk around the hospital and see these brown coat cuffs at the edge of your white coat.
Right, right.
It hasn't been laundered in forever.
When I was a resident, a patient had pneumonia. I said, what color's your sputum? They said, yellow, about the color of your coat. I'm like, okay, time to change my coat. Yeah, that's bad. When I can't give you a number of days you should change that, but we haven't gone to, we're going to cut all, make short sleeves for everybody. And I think it'd be impractical to have people wash up past the elbow in between every patient. We're just trying to get the hands right now.
So very good lecture. Thank you so much. You showed that the literature for contact precaution for MRSA is kind of controversial.
Right.
The question that I have is, what is the current CDC recommendation? What most of the institutions are doing for that? And also, it looks like we're going to be using that electronic badge. Is there any data for that?
It's too new to have good data. And then sister institutions, there's some that have done this. Crichton comes to mind. And then the other big brother institution other than UCLA is Cleveland Clinic, has done it for years. So other people have done it. As far as the guidelines are going to be updated, and I'll be curious to see what they say there. These don't say steadfast you have to use isolation, but they do recommend it in that 2006 to 2007.
We see other benefits from contact precaution. For instance, we like to use a lot of times the MRSA swab, even though this is also controversial to de-escalate antibiotics. Now, we're not going to be doing consistently or systematically swabs. So, do you see other benefits from the contact precaution?
Benefits other than de-escalating?
Yeah, other benefits in terms of increasing rates of infection.
Oh, no, I haven't, but I also don't de-escalate based on the nasal swab. Now, one reason, and it's not a good reason, but it is reality, this has kind of been tested already, in the sense that people have not been real good about contact isolation for MRSA. I've been rounding with the ID team, and a nurse will walk past the team, past me, past the sign that says contact isolation, and march right in the room. And if they're going to do that then, I mean, they're doing it every night shift and day shift. Usually I'll confront them and I'll say, hey, you just walked past the ID team, the hospital epidemiologist, and the sign. Sometimes they're defensive, and other times they're like, oh, I'm sorry, and they put their gown on. So fortunately, we haven't seen an increase in MRSA, if that can speak towards that.
Boris, one of your first slides was related to the rate of MRSA and VRE here. How does our institution compare, and I don't need the numbers, but a trauma center that also has a cancer center, tertiary hospital academic, how different is the epidemiology compared to a regular community hospital?
Ours is more, right, yeah. Our rates are higher and our reporting is more robust, and in a sense, it's just like hate crimes. No police department wants to report their rate because then they get labeled as the city of hate, So a lot of hospitals don't want to report their infections because then they get labeled as the infection hospital. We are here with academics in the university environment, and we're very good about and accurate about reporting our rates. So they may be artificially elevated a little bit, but nevertheless, it's higher in a tertiary university hospital, yes.
Okay. Any other questions or comments?